Okay, how is everybody doing? This is Dr. Philip May. I'll be speaking to you today on hypercalciuria. That's increased calcium excretion in the urine, and its consideration of relationship to vitamin D toxicity, osteoporosis, and kidney stones. In other words, hypercalciuria may reflect or be a manifestation of vitamin D toxicity. On the other hand, hypercalciuria is a risk factor for osteoporosis and kidney stones. The significance of hypercalciuria include increased risk for kidney stones, increased risk for renal failure, increased risk for low bone mineral density, and possibly an increased risk for fracture. What is the definition of hypercalciuria? There are a number of different definitions of hypercalciuria that practitioners use. Could use either a 24-hour urine collection or a spot urine calcium creatinine ratio determination. Looking at the 24-hour urine calcium determinations, a total urine calcium of greater than 300 milligrams per day for men and greater than 250 milligrams per day for women is considered elevated. Looking at another measure, using again the 24-hour urine calcium, the urine calcium concentration of greater than 200 milligrams per liter is considered elevated. Alternatively, one can calculate a urine calcium creatinine ratio if you're using milligrams of calcium per gram of creatinine, and this is an important consideration because sometimes this ratio is calculated using milligrams of calcium to milligrams of creatinine. It's a fraction of the milligram per gram determination, but using milligrams per gram, an elevated ratio would be greater than 220 milligrams of calcium per gram of creatinine. Another definition looks at the body weight. Total calcium excretion of greater than 4 milligrams per kilogram of body weight per day. So with a 70 kilogram person, that was about 150 pounds, 70 times 4, 280 milligrams per day using the body weight. It all comes out to about the same, around 250, 300 milligrams per day of calcium. If one uses the spot urine calcium creatinine ratio, whether you're using a 24-hour urine or a spot urine, is still 220 milligrams per gram. If you go on the Mayo Medical Laboratories.com website, you can look up these different tests and their normal ranges. It's pretty helpful to do that. It's sometimes difficult to get a 24-hour urine on someone with a developmental disability. Sometimes they're uncooperative, and it's not clear whether the spot urine is just as good as the 24-hour urine, but they do seem to collate. And here is just a very small sample of patients, 8 patients. You can see on the ordinate on the left there's a total 24-hour urine calcium determination, and the line at 300 milligrams is the upper limit of normal for men. And if you look at the x-axis on the bottom, you see the calcium creatinine ratio, milligrams per gram of creatinine is listed there, and you can see that the normal at 220 milligrams per gram ratio is on the bottom there, and you can see where they intersect. So the most of these patients were completely normal, in the normal range. Both their ratio and their 24-hour urine calciums correlated. However, there was one that had an elevated total 24-hour urine calcium, but the ratio was normal. So perhaps that should be repeated. I'm not quite sure what to make of that, but it doesn't seem to be quite as serious a condition as if both the total and the ratio were elevated. And diet can affect urine calcium excretion, which we'll get into in a minute. But one of the patients had a distinctly elevated calcium excretion. Both the total and the ratio were elevated. The ratio was 300 milligrams per gram, and the total was 380 milligrams per day. So it's important for the practitioner to be aware of different ways to test for hypercalciuria, which is probably a pretty common condition. Maybe 5 to 10% of everybody has some degree of hypercalciuria. And we're going to get into the different reasons why someone might have hypercalciuria. Now, these are 4 different conditions which are known to cause hypercalciuria. Basically, most of them are correctable conditions. And first is dietary, excessive dietary intake of calcium, sodium, protein, carbohydrates, and alcohol can increase the excretion of calcium. And also, if there's a reduced potassium, if you become potassium deficient or phosphate deficient, this can cause hypercalciuria. A second condition known to cause hypercalciuria is increased intestinal calcium absorption from vitamin D therapy, or overproduction of the active metabolite of vitamin D, 125 dihydroxy vitamin D, from primary hyperparathyroidism, which would require surgical removal of the parathyroid tumor, or granulomatous disease like sarcoidosis, lymphomas, hypophosphatemia from multiple causes can all be associated with increased intestinal calcium absorption, and these are all treatable conditions. A third category is increased osteoclastic resorption of bone from bony metastases from cancer, multiple myeloma. Again, primary hyperparathyroidism is associated with not only intestinal absorption, but also osteoclastic resorption of bone. Hyperthyroidism, Paget's disease, and importantly, for patients with disabilities, prolonged immobility. Many have motor dysfunction, and not getting weight-bearing physical exercise can be associated with increased losses of calcium in the bone. And there are other lectures in the series which get into that, on the effect of physical activity on calcium metabolism, and how the osteoclasts, or the osteocytes, I should say, become activated with prolonged immobility. Lastly, reduced renal tubular reabsorption of calcium can occur with loop diuretics, a number of renal tubular defects, and some genetic conditions can lead to a kind of a renal leakage of calcium, and that is the primary problem causing the hypercalciuria. Now, there are three pathophysiological mechanisms of hypercalciuria, or metabolic patterns that we see in these different conditions, which this is basically similar to the previous slide, but just giving a general overview to give you something to think about. The causes of hypercalciuria can be enterogenic, nephrogenic, or osteogenic. More often, all three of these conditions may be interacting, which leads to the hypercalciuria. Enterogenic hypercalciuria refers to increased intestinal absorption of calcium, which occurs usually from increased levels of 125 dihydroxyvitamin D, the active vitamin D metabolite, and this can also be seen with hyperparathyroidism because the excessive parathyroid hormone activates vitamin D. With nephrogenic hypercalciuria, the renal tubular problems that were mentioned before, and the osteogenic, the calcium is coming from bone, whereas with the nephrogenic, it's coming from the failure to be reabsorbed. And this can happen with vitamin D deficiency. Actually, vitamin D, the active vitamin D, stimulates the vitamin D receptor in the kidney, and this leads to reabsorption, better reabsorption of calcium from the urine. So it's counterintuitive. You'd think if you give vitamin D, this can cause excessive excretion of calcium in the urine, which happens if the intestinal absorption overrides the renal tubular reabsorption. But there is a fine balance there, and sometimes giving vitamin D can actually reduce urine calcium absorption. But more often than not, the net effect is that giving vitamin D does not really affect the urinary excretion of calcium at all. Now, the clinical determination of the common causes of hypercalciuria, looking at two different categories. One, if there is hypercalcemia versus a normal serum calcium. If there is hypercalcemia, then you should consider hyperparathyroidism, neoplastic conditions, vitamin D toxicity, or the milk alkali syndrome, just taking too much dietary calcium. And this can be associated with a normal or low serum parathyroid hormone because you're getting too much calcium. And secondly, if the serum calcium is normal, think of dietary causes, possibly vitamin D therapy, but it's unlikely that vitamin D is going to cause any significant hypercalciuria. But keep in mind that reduced physical activity or immobility, lack of physical exercise, or paralysis can be associated with hypercalciuria, as I mentioned before. And then lastly, there can be idiopathic hypercalciuria. A person definitely has the hypercalciuria. They're at risk for kidney stones. They're at risk for osteoporosis, and you just can't find a cause. So how do you evaluate the person with idiopathic hypercalciuria? This is a slide from Sella, who published a paper on this problem. And the patient This is for the patient who has hypercalciuria but a normal serum calcium and parathyroid hormone level. It's much easier if the calcium is elevated and the parathyroid hormone is elevated, but in the situation where the blood tests are normal but they have increased excretion of calcium in the urine, you place the patient on a low calcium diet. You get your dietitian to calculate a less than 400 milligrams per day diet. Leave them on that for 1 week and then determine the urine calcium creatinine ratio. And here this is milligrams per milligram. You'll notice that the normal ratio was that I mentioned before was milligrams for creatinine. So this is like a tenth of that. Actually, you have to multiply this by 1,000 to convert it to the milligram per gram of creatinine. But nonetheless, a value of 110 milligrams per gram is kind of the cutoff point here. After a fast, after a restriction of calcium in the diet for a week, it should be less than 110 milligrams per gram of creatinine. And if you show on the right-hand side there, if you do cause a drop in if the diet does reduce the ratio, then you've made the diagnosis. There's enterogenic or absorptive hypercalciuria, and that's how you treat it. You just restrict calcium in the diet. On the other hand, if it's still elevated, or not necessarily elevated, but higher than the post-fast level of 0.11 milligrams per milligram, then you have, by definition, fasting hypercalciuria shown on the left-hand side, and then you check the parathyroid hormone to determine whether that's normal or elevated, and that helps you differentiate more what's going on in your patient. This is an interesting study that was done looking at these were 12 different patients who had vitamin D deficiency and were treated with 50,000 units of vitamin D for a couple of weeks. And this is the effect of that loading dose of vitamin D therapy on people who were vitamin D deficient on the milligrams of calcium per day that they excreted in the urine. And on the blue bars, you can see this was before the treatment with the 50,000 units of vitamin D for a couple of weeks. And then the red bars is the milligrams per day of calcium that was excreted after the couple of week treatment with vitamin D. Overall, the means were not different. The mean urinary calcium was 212 milligrams per day before the treatment, and it was 195 milligrams per day after the treatment. But you can see the individual values here. And it's interesting, there were three individuals that had elevated, and these were women that had levels greater than 250 milligrams per day. And you can see with those three patients, patient 1, patient 3, and patient 4, that there was actually a reduction of 24-hour urine excretion of calcium, and these individuals with vitamin D, which is not surprising. It's consistent with other studies which have shown that in patients who have fasting hypercalciuria, that vitamin D may actually treat that condition. And if they don't have fasting hypercalciuria, it's not going to significantly elevate the calcium excretion. So it's safe to use. So having the concern that if they have hypercalciuria, that the vitamin D is probably not going to make it any worse. So if they're vitamin D deficient, that you should go ahead and treat the vitamin D deficiency if they have that. So looking at the problem of hypercalciuria and osteoporosis, hypercalciuria is associated with low bone mineral density, especially in patients with kidney stones. So there may be some condition that causes calcium loss, and the calcium is originally comes from bone, and it causes the bone density and fracture risk problems to increase. And thiazide diuretics may decrease calcium excretion in the urine and improve bone mineral density, and this may be a treatment for hypercalciuria. But in those who are vitamin D deficient, probably that should be corrected, and you may see that will help the hypercalciuria. In conclusion, hypercalciuria is not uncommon. 5 to 10% of the general population does have some degree of hypercalciuria. There is a risk for kidney stones and possibly fracture that results from hypercalciuria, so it is a significant problem. It's not completely clear what the best test is to diagnose hypercalciuria, but a combination of the total 24-hour urine calcium and the calcium creatinine ratio may provide the best clinical picture. Treatment should be based on the underlying cause or diagnosis. Thiazide diuretics may be of benefit. Treatment of vitamin D deficiency may improve hypercalciuria in some cases, especially when the parathyroid hormone is elevated. In my personal opinion, all patients with medically complex developmental disabilities should be evaluated for hypercalciuria for a couple of reasons. One is it may be contributing to low bone mineral density, which is very common in this population. And secondly, many are vitamin D deficient, and you will be using vitamin D probably to correct that deficiency, and this may promote bone mineral density, but the concern is always there that they may be getting too much, and this may lead to hypercalciuria. So you need to know whether they have hypercalciuria to begin with before you start the vitamin D. Is the vitamin D deficiency a pre-existing condition before you start the replacement therapy with vitamin D? So for diagnostic and monitoring purposes, probably initially a 24-hour urine would be ideal, but subsequent monitoring, a spot urine may be all that you need to do. But each person is an individual, and these decisions have to be made on a case-by-case basis. Okay, that concludes my talk. Thank you very much. If you have any questions, send me an email to ifcd.pmay@gmail.com. Bye-bye.